In this video, it's going to be a little bit different than my past videos. I'm going to be providing a meta commentary on the Why Can't We Cure Cancer NewsNation debate by Mr. Andrew Cuomo. And I thought that this would be valuable. I don't want to put out stuff that's not valuable, but I think that people want to hear my opinion on this, and I think that I share the opinion of others. So if I can provide some opinion of my own and have some agreeable points, maybe we can get even louder on social media together. So let's just get right into this, because this is going to be a very different format. It's going to be a longer format, so stick with me or not. If you want to skip around, be my guest, and I'm going to be talking a little bit about tweets that I saw. So let's get into it. The first part, and I labeled all this, I'm organized. The origination of chemo and radiation. Let's get
it. Could sound to my ears as if you're saying, fight it off, like it was a cold. Like that's the best thing we can do with cancer. Is like, make sure you have a strong immune system so that you can fight it off. What about medicine? What about treatments? What about what we thought this was all about, which is you giving me something to help me overcome it?
It's because of how we sort of started this 40, 50 years ago. We developed drugs, rightly so, to find a way to where we could shrink the tumor, but it came from a period of war. So nitrogen mustard, which was phosphine gas, was the first chemotherapy developed. So the idea was, if we go use this and it reduces the tumor and kills the tumor, and hundreds of drugs were developed as a consequence with that prism, we did not realize then, because the discovery wasn't made, so it's nothing bad by any people. In so doing, when we high dose, doesn't mean we never use the chemo. We knock out the very cells in our body that we were born with, that kills cancer, called natural killer cells and T cells.
Okay, so everybody should know this, that the natural killer cells and the T cells are our framework for fighting off diseases. And Patrick, I love this introduction because Patrick gives us an introduction to standard U.S. medicine 50 years ago. And I think this is really important because once you introduce a standard in the USA specifically that's decades old, it's going to be very hard to break that standard, even if you have revolutionary medicine. Why is that so? Well, because once you get 2-3 decades rolling, you get chemotherapy, radiation, you get the companies that benefit from that, and then you get the lobbyists, and you get the FDA, and the people together in a sort of like a group think. They work together and they pay each other from incentivize. So everything in this world is run on incentives. And so chemo and radiation have companies that back them, and they are incentivized to continue to sell these treatments to hospitals for continued use. And this is 50 years old. Good luck changing that, right? Even with a cure, even with a vaccine, it's going to be very hard, okay? That's the first point I wanted to make. Karen. Her name is Karen. I want to go back a little bit. Right here. These people, NIH, NCI, some private entity, out of public-private, I don't know. But NIH and NCI are the bodies that said in 2007 that the IL-15 is the key to treating and curing cancer. So these people are not really the enemy. And so they're not the FDA. And I'm going to get to the FDA next. And I don't know who this woman is. She sounds like a talker. And in my world, I lived in China for 10 years. They taught us how to identify talkers versus doers. And Patrick he's a doer. You see, he's very soft-spoken. He doesn't force his message. He does. He creates. He comes up with. He's a doer. And I don't know what these two people are, but she seems like a talker. It seems like, yeah, she's got the credentials, the MD, but do you really know what's going on? Find out.
This is your natural NK cells going at tumors that Dr. Pat showed me at this amazing sound and multimedia stage that he has out in LA. So, all right, so help me understand. I don't get it, Karen. If you know that this is what it is, and the thing that came in number 2 on the list behind IL-15 has become like all the rage because some big pharma company has a big drug for it. Why isn't that the focus?
Well, the science had to mature and the science had to get from the lab into clinical testing. And there are a lot of bottlenecks there that would be worth talking about. But what we know about immunotherapy now in 2026 is very different than we knew in 2027.
27 hasn't happened yet, Karen. Thank you. What's your point? The science has to catch up. Are you doing your homework? Are you doing your research? Do you see that the science is catching up? Do you see that IBRX and Anktiva is at that critical point? We're not talking about hype here, ladies and gentlemen. We're talking about 86% complete response. We're talking about complete responses that are way above the median not yet reached. So what are you doing here? Have you done your research? Do you know who Patrick Soon-Shiong is? Do you know what Anktiva is? Because you sound to me like a generalist, not a specialist. Do you guys understand what I say here? A generalist knows a little about a lot, a little about a lot. A specialist, cancer, Dr. Patrick Soon-Shiong, knows a lot about a little and probably knows a lot about a lot.
And where we are,
They said it was number one in 2007.
2007. But where we're entering,
People are laughing at her.
Is
People, I heard laughter in there.
a phase where saying immunotherapy is going to be like saying telebanking. There's going to be some redundancy there. Literally all cancer therapies are going to have a root in the immune system. Even what we think of right now as standard chemotherapy or radiation therapy, and there have been approvals already in this space, are being driven specifically to tumors, like a smart bomb developed against an...
I noticed she's using metaphors. You don't use metaphors in science like a smart bomb, like a HD TV, like a this, like a that. I'm not saying she's stupid. She's got an MD. I'm saying, what is she doing here? She sounds like somebody that's an educationalist. People in the FDA are educationalists. If they knew how to cure cancer, they'd be doing it. If they knew how to work on cures, they'd be doing it.
Antibody, an immune component that's directed against a protein decorating the surface of a cell. But what's curing people now?
Look at Patrick looking at her like he really wants to interrupt her, but he still is soft-spoken, polite, a genius, Elon Musk of biotech of our time. And I just love the look.
Like advanced lung cancer, like bladder cancer, like melanoma, are the kinds of immunotherapies that take away the tumor's ability to cloak itself from your immune system. That was there have been a couple.
I'm going to stop it there because the point has been made. Let's move. At 2540, this will be fun. Let's just get into it.
Early phase novel therapies.
So
Every patient's on clinical trial and no one pays. So having run one of those NCI designated cancer centers, one of the 73 that you talked about, and run on top.
So she runs centers. That's a really important point. Having run centers, she sounds like a manager, like a CEO. She doesn't sound like a scientist. She doesn't sound like she's somebody inside the data, inside looking very closely. Again, she knows a little about a lot. That's what CEOs do. That's their job. That's what they get paid the big bucks for. That's why she's able to run 70 centers. She can see a little about a lot, but she cannot see the details. She's not designed for that.
For a 16 hospital system across 2 states, I would wake up every day trying to determine how it is that...
Would you really wake up every day, Karen? Okay.
We were going to lift up more phase 1 studies because...
So we were going to lift up more phase 1 studies. Is she the FDA? She is not. So why is she speaking like the FDA? There's so many red flags about her. I just don't understand why was she even brought here.
In cancer, that is the most advanced form of care. And you want more people to have access to that.
She sounds like she doesn't even know that interleukin IL-15 is even the best cancer treatment. She sounds like very airy, like airhead, like I'm going to recommend all these things and we're going to target cancer. That's talk. That's not do.
I think technology is going to help us get there. But at the end of the day, it's who's going to fund the study.
May I just respond to?
Please respond, please.
For 10 years, I've been working with the NCI and the creator, with Jeffrey Sloan. For 10 years, we've been in the trials. You sound as if you don't know that we've done hundreds
You sound as if you don't know that we've done hundreds of. So he knows that she knows. Okay.
of patients, triple-negative breast cancer, Merkel cell carcinoma, pancreatic cancer, head and neck cancer, which we're getting not only responses, but complete responses.
I'm talking about the field writ large.
No,
Patrick.
we're
So
not talking about
not
the
just
field.
yours.
I think
Again, I'm talking about the. No. And Patrick rightfully steps in because he's very polite and soft-spoken, and he's a real, genuine genius. And I'm not. I would shove her out of the way and say, listen, we're talking about IL-15 because the guys next to you, Karen, NCI and NIH, had told us that IL-15 is the key back 20 years ago.
tonight we're talking about IL-15.
I
This is exactly what happens when we get into these conversations about epidemiology, big picture. We have patients, and more importantly, the science has actually identified this molecule called IL-15 that our body makes. The NIH, to their credit, has tried for a decade to actually make IL-15 work to stimulate NK cells. I then, with Jeffrey Schlom and with James Gully, for 10 years have worked together in collaboration.
So you're actually doing clinical trials with the NCI. The NCI
Correct.
is assisting you in doing clinical trials.
With Crater. In fact, Jeffrey said, I'm okay to say this tonight. These 2 5-year reviews were the best that he's had at NCI because of our work together on the IL-15.
And why doesn't anybody know about this? Because he's being silenced. Because it's the same bureaucratic nonsense, the same airheads at the FDA than we see with Karen and the bald guy here. The bald guy is NCI. So how does he not know? Has nobody done their homework?
That stimulates your natural killer cells that are shown to actually give complete response. So let me give you some information. We have patients with bladder cancer, 10 years free still of cancer. Patient with Merkel cell, 6 years free, didn't die of cancer. Patient with metastatic pancreatic cancer, 7 years free, did not die of pancreatic cancer. And we can go on.
But here's the issue, though. Okay, and again,
I'm going to stop it there. I just wanted to hear what Patrick had to respond to her and also comment for you guys. Let's move on. This is a good one. You guys are going to like this commentary. 3004. I'll go to 2952. This is the former FDA. Oh, look at that. Associate Commissioner. You don't think he doesn't know anything? He knows everything that's going on in the FDA. And he's a bookworm. I mean, come on. He tells us that the FDA is very segregated, which we already know. And again, people that work in the FDA, like I just said earlier in the video, people that work as scribes, as journalists are the lowest of the low. They can't get jobs as analysts. I know this. I was an analyst. I was a macro analyst in China for 10 years. We have journalists, they don't know anything. So Adam Feuerstein, I don't even know if I'm saying that right, Feuerstein, he's got this vendetta against small and mid biotech, and it's unfair. And he has this opinion that I've exposed today on my Twitter. I'm not going to give him any airtime. I don't think he deserves it. But I exposed him today using Grok, using AI, because he does have 20 years in the industry. So he is able to use gray area language against us. But let's go on. And
NIH and this and NCI for the folks that you're granting, saying, listen, we're not going to continue to write you guys checks to do the same things. You guys have to actually have a result.
But I don't think it's this. I don't think it's this part of this. I don't think it's this part of the train. The reason I was so excited to have you tonight is I think that the problem is when Pat gets to you, is he has the research.
Yes,
He's come through these channels, and then it seems, and not just Pitts. He was the commissioner, but he's good enough to be here tonight. But go ahead, Pat. Explain the situation.
If I asked you a question, former commissioner.
Associate Commissioner, but thanks for the promotion.
We now have these results that we have now prolonged the survival of patients with lung cancer where there's nothing left for them to have. They failed chemo, they failed radiation, they failed checkpoints. We take the patients that are progressing on checkpoints and add an NK cell to that, and all of a sudden we've tripled their survival. Would you now say it's ethical for me to do a randomized trial of that patient to say, go get some more?
That's a great point, because the problem inside the FDA, in my opinion, again, it's easy to have these types
He's going to explain it to us right now, and it's going to be very diluted, very boring. Let's try and listen to him.
Of comments once you're outside the agency is that career staff at the FDA, underpaid and but highly motivated and very
underpaid and highly motivated. Why do you think that is? In America, a capital market, you get paid for what you do. You get paid for your skills. An analyst on Wall Street gets $250,000 a year, while a scribe gets maybe $80,000 a year, right? A doctor in the emergency room gets paid $400,000 a year, while a dentist's assistant gets paid $80,000 a year. Why do you think that is? It's because skills count. Your skills get paid. So why are they underpaid? Because nobody will hire them, in my opinion. Nobody wants them. So they go to the FDA with a chip on their shoulder.
very dedicated to their tasks are not always risk takers. In fact, oftentimes
Yeah, they're not always risk takers. That's an understatement.
they are deterred by management at the FDA from taking risks, from going outside the box to thinking.
So what he's saying here, and this is a really important point, is that risk-taking equates to me as to small and medium cap biotech. Risk aversion to me, if I'm going to think like an FDA, GlaxoSmithKline, Pfizer, Johnson & Johnson, low risk. Why? 200 billion market cap, 100 billion market cap, 150 billion market cap. They're the big boys. The big boys can't be wrong, can they? That's typical groupthink mentality, and it doesn't allow innovation. If you treat people, if you treat organizations like this, you are never going to jump the technological curve. You're going to always stay behind. And that's what Saudi did to America. They jumped the curve. They jumped over America by saying, we don't care if you're big or small. We look at the numbers, we assess the risk, and we approve or decline. And they approved.
Differently, Patrick, to your point. And that's got to change. I think, Dr. McCary, the current FDA commissioner, has a new article out on kind of new ways to do only one large trial versus two large trials. And that is a...
McCary is new. I've heard some good things about him. This guy seems okay to me. He seems like a nerd, just a bookworm. And when you get bookworms together in a room, nobody takes the lead. No, in my opinion, nobody's going to say, we got this IBRX here, let's approve them. And all the other bookworms are going to say they're too risky. Again, this is my opinion, just based on living life. Let me also go over here and cover this. The FDA vaccine chief, Vinay Prasad, set to leave post next month. Prasad's departure could be a positive. He pushed for randomized trials even in late-stage cancer settings. That's what this dude was just saying, like 2 trials versus 1. Like, repetitive redundancy gets us nowhere as Americans, ladies and gentlemen. America became a great country because of innovators, because of risk takers. You're going to make mistakes. Take the risk. You're going to make mistakes. That's inevitable. You cannot be perfect. Look at how much risk they took on those COVID jabs, and look at how big of the shit they were. That's a big risk. Why would you take it with the COVID jab and not with something that has 13 years of provability of results? Anyway, let me get back on task. ImmunityBio's trial design seems more practical, randomized studies. Dr. McCary recently praised the FDA's unprecedented agility. Okay. Yeah, that was good. Yeah. By breaking the 2-trial dogma and launching the PMF, you have proven that the agency can prioritize patients over bureaucracy. So my friend here, Bullish Brock, he likes this. He likes the what's going on. I look at this guy, I think he looks like a menace to me. But let's see what the investment banks say, right? Let's see what they say. Where's my banker? The end of Prasad's tenure is a sigh of relief for the biotech industry. BMO Bank of Montreal Capital Markets analyst Evan Segerman said in a note to clients, adding that him leaving the FDA improves the chances of several companies getting their drugs approved and may alleviate the uncertainty facing vaccine makers. Couple of small caps jumped on that news. Respectfully thanked him for his service. He didn't join too long ago. He joined 2025. And it looks like they botched Sarepta Therapeutics. So it looks very volatile for this guy, and good riddance to him. What else did I want to cover? This guy already covered him, Firestein. I don't like him. Nobody should like him. He's, I think he's aligned with big tech, to be honest. Here's something I can cover. For those IBRX early investors who values the science and growth, you aren't buying a stable company. You are buying a miracle drug and a platform that will become the backbone of future healthcare. If you want to screenshot that, you can, but he draws parallels to Tesla and NVIDIA. Good point. No risk, no reward. Listen, I'm a finance guy. I'm a risk taker. But I'm not a blind risk taker. I look at the data. The data tells me take a risk. 85% complete response, 79% complete response, lung cancer, pancreas cancer, glioblastoma. Am I missing anything? Of course, bladder cancer. And I've been a shareholder for a long time, so I want to see him win because I'm a shareholder because I believe in them. I took a risk, and now I'm getting rewarded just like all of you. One final thing that I posted this morning, I said good riddance to Vinay Prasad. This matters for IBRX because Anktiva is reviewed under this exact division. News to me. Very interesting. If you don't know yet, Dr. Prasad has been a very public critic of Dr. PSS and Anktiva. I also didn't know that. There's for sure some beef between them. Dr. Prasad is always known to always push for stricter evidence standard and has been skeptical of approvals based on smaller or single-arm trials. Again, this is a big biotech versus small biotech thing, and this is about being risk-averse versus being risk-taking. And the definitions of risk aversion is going with big biotech. That's wrong. That's like a recency bias. That's some sort of behavioral bias. Because small biotech can absolutely have the same or better results that a big biotech can have because they're more flexible. Him alone could signal a shift in regulatory leadership and philosophy. Fantastic. Let's bring it on. This is the year of IBRX, the fire horse, the Chinese New Year of the fire horse, and IBRX is going to be fire this year. Thank you, everybody, and I'll see you in the next video.